Before we get started, I would like to introduce myself, our speaker, and share some housekeeping information. We are recording the webinar this evening, and we will be making it available on demand. If you're experiencing difficulties with the audio or video, usually the best solution is to log out and then log back in. If that doesn't work, we will be sending out instructions on how to view the on-demand version in a few days. So please watch for communications from us about that. There will be a handout that will be made available. We'll post that on our website for those that are interested. I would like to say thanks to Proadaptive Medical Innovations for their partial sponsorship of this webinar. We rely on corporate partnerships to bring you quality courses and to help your patients and communities. Oh, I can see that there's somebody saying that the audio is quite low. Just one sec. I'm just going to see if I can adjust the volume here. Just give me one sec, everybody. I just turned everything up. I hope that's a little bit better. I'll try and speak up a little bit as well. So first off, I would like to, the webinar is an hour. Sorry, I just cut that out of the corner of my eye. My name is Wendy Jobs, and I'm your moderator and host for the webinar this evening. I would like to take this opportunity to recognize all of the traditional territories upon which dental hygienists work. You should be directed to a survey at the conclusion of the webinar, so please take a few minutes and complete this for us, as your feedback is very, very valuable, and it helps us make decisions about future events. I am the manager of dental hygiene practice for BCDHA. I've been with the association for several years now. I love my job. I was an educator in a dental hygiene program for 20 years. I've worked in residential care, a perio practice, and numerous general practices. I have one dog, one elderly dog, and 3 grown children. So thank you very much for attending. We very much appreciate that. So just a little bit of housekeeping. This is for those of you that are new to Zoom, which I doubt very much with COVID. Everybody's probably had experience with this. So there are a couple of features. You can adjust your audio settings in here. You can turn up the volume. And I hope still too low. Okay, hang on. I'm just going to, I apologize for this. I don't have a technical person right now helping me. So I'm just going to turn that up a little bit. Let's see if that's a bit better. Okay, there we go. If you move your mouse around, you'll have the toolbar should pop up. If you have a tablet, sometimes you have to touch your tablet. I see volume much better now. Okay, thank you very much for that feedback. I appreciate it. We won't be using the raised hand section because there's too many of you online. I see that there's already 456, 457. So thank you for being so patient here. We will be using the chat. If you use the chat to tell me certain technical things, if you're having, you can chat with one another if you see a friend or a colleague on there. If we can use the Q&A to send me questions that you would like me to pose to the presenter, I'll try and collate those and ask those at the end of the session. So that's how you can access the Q&A. You can send things anonymously, but you can certainly let the entire group see your questions if you're not shy. So just a reminder, oh, sorry, I think my slide didn't advance there. There we go. Just a reminder, this is the suggestions we have for your QAP. Don't forget, you must log into your online platform and add this particular learning activity to your particular plan. BCDHA does not offer completion certificates. So the best suggestion is to keep your registration information, your notes, and any other documentation that you might have made that demonstrates your learning. CDHBC has also made it possible to upload electronic documents so that you can scan and house this type of information directly in your online profile. Remember that what we're suggesting here is only just suggestions. It's up to each member to decide how this event best fits into your professional development plan. I just want to do a quick plug that we are hosting 3 more additional webinars, one in March, one in April, and one in May on HPV. It's a well-renowned speaker, Joanne Jones, so we welcome you to register for that series. You can watch one or all 3 in concert. We will also be providing those on demand, so you can access the registration information there. So I would like to introduce, and Martha, I'm going to let you say your own last name because I'm always afraid I'm going to mess it up. Martha is a dental hygiene practitioner and professional educator who utilizes evidence-based practice and experience from a variety of clinical settings to help dental professionals stay current in the ever-changing world of dental hygiene. Martha holds a Bachelor of Dental Science in Dental Hygiene from UBC, a diploma in dental hygiene from the College of New Caledonia, and a provincial instructor's diploma from Vancouver Community College. Working in dentistry since 1998, first as a certified dental assistant and 15 years as a dental hygienist, Martha has worked in several practice settings. She has held positions in community dental health and dental hygiene education and is currently employed in long-term care, private practice, and professional education. I am proud to say that Martha is a former student of mine, and I value her contribution to this webinar and to the dental hygiene community. So thank you, Martha. And I'm going to bring her on in just 1 second. We are going to launch a poll question. So I'm going to launch in just a moment here. Get some water. I would like to pose a question to the group. So if everybody could answer this question, that would be great. So are you providing any aerosol generating procedures, including your triplex or your tri-syringe? So I can see lots and lots of activity right now. People are answering. That's great. That's wonderful. Well, you guys are quick on the draw. We have some probably very experienced Zoom users here, especially with the polls and responding to questions. Let's see, things are slowing down. Okay, great. We're not going to share the poll results right now. We're going to wait until the end. We're going to keep you in suspense. So I'm just going to end the polling now. I'm going to get rid of that. And I'm going to turn things over to Martha. So thanks, Martha. Thank you very much for providing this for us. I appreciate it.
Okay. Hello, hello. And oh, if you can start my video, Wendy.
I'm sorry. Apologize. There we go.
There we go.
Thank you.
Thank you. And I'll just share my screen as well.
Yeah, thanks, Martha. We really appreciate it.
Oh, my pleasure. For those of you that don't know me, my name is Martha Shapulski, and yeah, I'm a dental hygiene practitioner here in Vancouver, BC. Born and raised in Vancouver, but I did do a brief immigration up to Prince George to do my dental hygiene program, and then I returned to Vancouver again. As Wendy said, I've had the pleasure of doing a bunch of different opportunities in dental hygiene, and it's something that I thrive on. And during COVID, it actually became a new thing that I thrived on. I joined up in a partnership with a company called Prodaptive Medical Innovations. And they had a product, and they wanted to see if it would be applicable to dental hygiene. So for the first time, even though I've done clinical practice, I've worked as a dental hygiene instructor, I've worked in some other things with dental hygiene, this is the first time that I could start to try to find a way to make dental hygiene safer. And so I think I've had a lot of aha moments, you know, during COVID, as I'm sure you guys all have as well, you know, learning about yourself and learning about your relationships and learning about your job and everything. And this presentation is a culmination of a lot of the things that I've discovered about our profession as I've been learning of how to work and how to adapt during COVID-19. And I'm just going to be sharing that with you guys. I'll make it a little bit more formal in just a moment. But yeah, the full disclosure is that I'm currently working as a consultant for Prodaptive Medical Innovations. And yeah, what we're doing is we're trying to work to find solutions to make dental hygiene and dentistry safer for the operators as well as patients. So a little bit more formally, this is what our learning outcomes are this evening. We're going to talk a little bit about COVID-19 transmission theory as it applies to dental offices in the current conditions and what's the current research that's going on right now. Then we're going to look at the hierarchy of controls, especially in relation to dental hygiene and dental office examples. And by the end of this, you're going to feel really comfortable with looking at a protocol and determining what part of the hierarchy does this belong in. We're going to briefly talk about something called the layering principle, which is the very important principle in regard to the hierarchy of controls. Then we're going to take a look at some novel safety innovation and what is the relative position of these safety innovations within that hierarchy of controls. And again, you're going to be able to use it not just for the one that I show you today. You're going to be able to, as I'm sure there's going to be a host of innovations that are going to flood the market in 2021. Everybody was kind of shell-shocked in 2020. How do we work safely? What protocols are best? We did a lot of this sort of work, and groups like Productive and other groups were all looking forward to try to make dental hygiene more safe. And you're going to see a lot of different things. And I want you as a dental hygienist to be able to evaluate a tool and say, this is where it belongs on the hierarchy. How does this combine with my other methods that I'm using to protect myself and my patients? And would it actually be valuable? Is it worth the money? So on and so forth. And then there's sort of, that's like the first half of the presentation. And then at the very end, I also had a lot of aha moments with ergonomics, because that's the other key to dental hygiene safety during COVID-19. We have the minimal aerosol generation protocols now, so that meant a lot more hand scaling. So we're going to do a little back to basics. If you're feeling fatigued with all this hand scaling, I'm just going to give you a few tips and tricks that I found for myself so that I could scale with more comfort and ease. And they were so simple, yet so hard to do when you're in a time of stress, you forget about them. And also we're going to take a look at the big white elephant in the room, the HVE, and how can we make that HVE more comfortable to use? And I have a solution that I'd like to share with you. So before we go into COVID-19 in the modern world, I want to talk a little bit about how we got here in the first place and an interesting historical story about where we came from in the fight against bacteria and viruses. What was life like before Universal and Standard Precautions? This illustration here is of a doctor named Dr. Ignaz Semmelweis. And he was a Hungarian doctor. He worked at the Vienna Teaching Hospital in the 1840s. Now, 1840s Vienna, this teaching hospital was world-class, and it was just state-of-the-art, and they were teaching lots of students. It was amazing. And if you're thinking, what was life like in 1840s? Well, this is like 25 years after Bridgerton, so that's kind of the era that we're talking about. And if you don't know Bridgerton, it's a very delightful Netflix show if you need a little guilty pleasure escape. But anyways, that's a sidebar. Dr. Semmelweis, he worked with the physicians, and there was two giant maternity wards, and one was the physicians and their students, and the other one was midwives and their students. And interestingly enough, in those days, the wealthy didn't usually give birth in a hospital. It was more for the middle and lower classes, and even women like prostitutes and things like that would go to the hospitals. And there was a phenomenon that was occurring that women would actually be staying in labor, waiting to get into the hospital on days that the midwives were accepting new patients. And they alternated, the doctors and the midwives alternated who was accepting patients on a given day. Why did they do that? Because they realized that there was a much higher fatality rate for the mothers if they were on the doctor's ward. In fact, Dr. Semmelweis started collecting statistics over several years in the 1840s. And the rate of death of the mothers by something called childbed fever, which was essentially a streptococcal infection, was about 3.6% on the midwife's side and 9.8% on the doctor's side, almost 1 in 10, very high fatality rate, which you can see why the women of the age really wanted to be with the midwives. He started to look around, he was trying to find the cause. Why is this happening? And he actually did come to a conclusion. The midwives and their students, they worked exclusively with just the maternity ward, whereas the doctors, they would go to their science laboratories and they would work on cadavers and do all their whatever they do with the cadavers, and then they'd head into the maternity ward and they work on these expectant mothers. And he surmised that something, and he didn't know what, was being transferred from the cadavers to the mothers, and the doctors were the vector bringing it over there. And he advised hand washing. Well, in 1840s, state-of-the-art hospital, He was laughed out of the building. The doctors rejected his hypothesis. They're like, what could possibly be transferred? There was no recognition. He tried and battled to try to get people to listen. Didn't work. He tried to publish. He was also mocked in the literature. He unfortunately, sadly died in a mental asylum of an infection that they think happened from a beating. Sad story for Dr. Semmelweis, but he was on the right track. Fast forward into the 1870s, another doctor, Joseph Lister, was working off of work by Dr. Semmelweis and other scientists of the time. And he started using carbolic acid on wounds and on instruments. And he also recommended hand washing because there was starting to become a recognition that something was being transferred. And it was like right around the turn of the 1900s starting that it actually became a general practice, that it became widely accepted. It took about 60 years for these sort of practices to become widely accepted, that you should wash your hands in between patients and wash your hands after touching a cadaver. So it just kind of goes to show two things. Number one, that how far we've come. And number two, that sometimes novel ideas, we can be resistant for a variety of reasons, and we need to be open to new ideas, especially in the face of new challenges and new changes. And if you're curious about Joseph Lister, is that as in Listerine? The answer is yes, but Joseph Lister did not invent Listerine. Listerine was named as an homage to Joseph Lister by some other scientists that made it, and it was used for a variety of different reasons. Let's fast forward to modern times, late 1970s, early 1980s, the HIV epidemic comes along. And we realized that prior to that, people were kind of a little selective. Like if you thought your patient was healthy, you might not have as stringent health behaviors around them as you would with a patient that you thought was ill. Then you would be very meticulous with your hand hygiene and sterilization. With HIV, they realized that this was a bloodborne disease. We needed to protect ourselves from these bloodborne pathogens, and that all patients should be treated as potentially having it, because some people didn't know that they had the disease. So that changed everything into universal precautions. Basically, everybody is doing the same thing. It's universal, and it's the things you see listed. Standard precautions is just the newer version of universal precautions. It came around into the 1990s, that terminology, and it just said not just blood is dangerous, anything that could be any fluids from the body, so saliva or anything else. Only kind of sweat is kind of like still safe, but everything else we want to treat it as if it could be a vector for disease. Fast forward a little further. Now let's talk about dental and into the CDC 2016 dental settings summary. Now we're protected from our bloodborne stuff. We're doing all our hand hygiene, but along comes airborne and respiratory stuff. The CDC back in 2016, so not that long ago, they basically said if there was going to be anything that was airborne, that we're actually not designed to carry out any of the transmission-based precautions for airborne. But they said, however, patients do not usually seek out routine dental outpatient care when acutely ill with diseases requiring transmission-based precautions. So, but they said, nonetheless, we should develop and carry out systems for early detection and management of potentially infectious patients at the initial points of entry to the dental setting, and rescheduling non-urgent dental care until patient is no longer infectious. So this was in response to thinking of things like measles or chickenpox or TB, which are actually airborne. COVID is actually still primarily considered a respiratory transmission as opposed to an airborne. But the jury's still out. We don't know if it's actually going to be having how it's transmitted via aerosols, because that's something that we generate. Does it make it more like an airborne? We still don't know. And the whole thing of COVID that makes these 2016 recommendations almost impossible to implement is the fact that they're based on the assumption that a person who is symptomatic won't show up. But with COVID-19, yes, we are telling the symptomatic people not to come. However, there's asymptomatic carriers. Depending on the group, there was a study done by the Center for Evidence-Based Medicine out of Oxford, and they said anywhere from 5 to 80% of people testing positive for COVID, they may be asymptomatic. It depends on the population group and the setting. And so symptom-based screening will probably miss some of these folks. And some of these are pre-symptomatics, which means they will develop symptoms over time, and some remain asymptomatic altogether, but they are capable of transmission. Let's take a look more closely at COVID and BC. So the latest in COVID, I'm sure you guys have heard about, is the mutation variants. So what's been happening in the recent months is that there's been several mutations of COVID. In fact, there's actually been mutations going on for a very long time. There's over 100 mutations by the end of 2020, but there's certain variants, combinations of these mutations that have actually come together, and they've made, in certain cases, COVID more transmissible. There's generally, right now, there's 4 different variants that have been located around the world. There's the UK, South African, then there's the Brazil, and there's also the Californian or US variant. In British Columbia, these statistics were as of Sunday evening. They were most current at Sunday evening, so there's probably a few more numbers than on my slide right now. There was 72 people in British Columbia, 52 with the UK variant, and 20 people with the South Africa variant. So the concern with that is that it's more transmissible, which means it's not going to necessarily be more fatal or have more severe illness. It's just that if you are not practicing the precautions that we've been asked to do, such as social distancing and mask wearing and staying in your bubble, you're going to have a much more rapid spread. For example, they say that if you had regular COVID-19 and it was spreading through a population and 100 people got COVID, if it was the UK variant, 160 would get it if there was no precautions. So again, just more transmissible. But on the bright side, vaccination is underway. Again, these stats now are from Sunday, so we've had a couple more days of vaccinations. So I know that there's well over 200,000 initial shots, and I think it's somewhere in the 60,000 range now for the second shot. I'm not sure exactly. And basically long-term care, the majority of people have gotten their second shot. All of the acute care hospital people have gotten at least their first and working into their second shot. Projections are that 10% of the BC population are going to be inoculated at least with their first shot by the end of March. Starting with the elder population, so people over 80, they're starting the rollout. And how exciting, guys, I'm sure you saw the college outline showing that dental hygienists will be part of the select of group of health professionals that will be able, with special training, to possibly be administering COVID-19 vaccines. Super exciting, but we have to wait on the college to hear more about that. But we can definitely be a part of this solution. Let's talk a little bit more now. So we've kind of moved through time. We've gotten here. We've talked a little bit about what's going on and what's current and things like that. Let's break down exactly how we catch COVID, and especially to the dental setting. Let's talk about infections. Basically, this is not just for COVID, but for any infection. You need 5 conditions to be present. The first is a pathogenic organism, and it has to be sufficiently virulent and also in adequate numbers to cause disease. And so if you are not practicing all of the standard protocols as recommended by the Provincial Health Office, you will be at times encountering adequate numbers. But if you're masking and social distancing, you're probably going to avoid those adequate numbers to cause disease. The second condition is a reservoir or source that allows the pathogen to survive and multiply. In the human body, that reservoir is in the nose and the mouth and the oropharyngeal tract, and it can actually eventually lodge into the lungs, and that's where it can survive and multiply and cause damage. You need that mode of transmission from the host to the source. Again, right now that is respiratory droplets, so coughing, sneezing, talking, singing, all those kind of things, especially for a long duration. The longer the duration, the more forceful the breath, you're going to be getting those adequate numbers to cause disease. You need portals of entry through which the pathogen can enter, and COVID is your eyes, your nose, and your mouth, so covering those, you can definitely reduce that. And lastly, the susceptible host. And with COVID, the most susceptible hosts are those that are immunocompromised and elderly. And we have seen actually already, if you're following the stats, is that BC has had a drop in the fatality rate of COVID-19. And it seems likely that the reason for that is the vaccination program, and it's very, very promising. let's take a look a little bit about how this applies to dentistry. Because there's one thing about going to a party and talking to people and things, but then there's dentistry. We ask patients to remove their masks. We don't social distance. And oh, by the way, let's like kick up your saliva, which absolutely can contain COVID-19. Saliva is actually a reservoir for COVID-19. So what can we do here? Well, let's take a look at actually breaking down the difference between splatter and aerosols. Aerosols are very, very fine, and actually they're generally defined as being actually less than 50 micrometers in diameter, and they have the ability to float. So aerosols can float around. That is why they're the chief concern in any sort of airborne transmission disease like measles and chickenpox and TB, because it has this ability to just kind of hover in the air and flutter around. Then you've got splatter, and splatter is anything that's 50 microns or larger, and it acts differently. It will fly in a ballistic manner, like a bullet shot out of a gun, and it can hit anything. And generally, splatter, when they take a look at how far does it go, you're anywhere from 18 inches is like the big splatter zone around an area where you're generating any sort of spray. So it's going to be hitting your PPE, it's hitting primarily on your arm and chest, it's landing on your patient's face, it's landing on your patient's garments, on the chair, and on the floor around you as well. Now, the thing about splatter is that obviously it bears resemblance to respiratory droplets, which is kind of concerning with a respiratory disease. But the other thing is that the splatter flies, it lands on whatever surface it lands on. And then it actually has the potential to become aerosolized as it evaporates. And that is also a concern. So if you don't control splatter, you're not going to necessarily be controlling all of the aerosol. It's sort of like this hidden like sneak away that's getting out and everything. And as you can see in this image here, this is our innovation that we've been working with. It's called the Stahlshield, and it is a capture guard capturing splatter so that you're taking the power of your high volume suction for containing aerosol, but it doesn't contain splatter, and it's not very good at sucking up saliva at the back of the mouth, but absolutely excellent for capturing aerosol. Combining these two tools together to make your HVE a better tool. As I was doing a little bit more research for you guys for this, I found some good terminology to review. As I said, right now we're going to see a bunch of studies coming out, and here's a gist of where research is going in the search for dentistry safety and aerosol generating procedures. Prior to COVID-19, almost all of the studies you'd find in the literature about aerosol generating was aerosol generating medical procedures. And there's almost nothing about aerosol generating dental procedures. And in fact, they usually just called them AGPs. They didn't even differentiate between the two, but typically they were alluding to medical procedures. The big difference between the two is that when there's an aerosol generating medical procedure, they're trying to stimulate or simulate a cough reflex, and they're trying to mechanically disrupt the contents of the respiratory tract, or that's a byproduct of a procedure they're doing. So that is how things are getting aerosolized. Dental procedures are completely different. We're not trying to do any of those things. In fact, that's the opposite of what we're trying to do. What is happening is you have the wet oral environment, typically in combination with water from dental unit water lines, and that's aerosolized by some sort of, rotary instrumentation with the high speed or the ultrasonic. There's a new term that's coming out in the literature as well that I want you guys to know about, and it's called aerosol generating exposure. This is coming from the idea that there's a lot of modifiable risk factors that exist with aerosol generating procedures. And you're probably already in your practice doing things to mitigate aerosol generating exposures. The very fact that we're choosing to do minimal aerosol generation is an aerosol generating mitigation, right? So taking a look at these sort of things, there's a lot of factors that we're going to be looking into, and we're not going to be looking at it so much as aerosol generating or non-aerosol generating. Things are going to become a spectrum in the future. Two other terms that I want to share with you guys in relation to aerosol generation in dentistry is physical decay and biological decay. So if you see that terminology, the physical decay refers to just how long saliva droplets are going to stay in the air. But the biological decay is whether those droplets remain infectious, because that's really more our chief concern is how long is that biological decay and the quantities and so on and so forth. So this is all research that's being looked at right now. The other ideas to share is that I've already read 2 articles from early January 2021, one from United Kingdom, the other from North America. And they're both leading towards the same conclusion, and that's that aerosol generating versus non-aerosol generating, it's a too simplistic of a model. It's like this binary thing that it's like one is safe and one is not safe. And it's actually, you guys probably already can think to yourself, but that's not really true. It's not that simple. As most things in life, it's not black and white. There's always shades of gray. And they think that we should start in dentistry considering that aerosol generating exposures are actually a spectrum of risk. And the authors are talking about like making a model where there's a low, a medium, and high risk model. And they think that these models should be flexible because as more data comes in from studies, we are going to be determining exactly what is low and what is high. The other thing that was very interesting that came out of looking at these studies is that internationally, there is very little consensus on which aerosol generating procedures are high risk and low risk. The only real consensus is that the high-speed handpiece and that the ultrasonic unit are high risk. After that, it gets a little bit gray. For example, the authors cited that in Canada, we consider using a rotary slow-speed handpiece is a high risk, but in the United Kingdom, it's considered low to medium risk. So depending on the country, depending on the province, we're seeing a variety of things. So the authors are calling for the international community of dentistry to come together and try to make more universal modeling. And it's going to be based on a flexible scale, and it's going to be based on whether procedures are low risk or high risk, how long you provide them for, the health of your patient, et cetera, et cetera. So expect that things are probably going to change in that direction, and that's how we're going to gain our flexibility in providing aerosol generating procedures is as we gain more knowledge and start to look at the spectrum of risk versus AGP, non-AGP. Other data that's been coming out, they've been doing some analysis now of what's in the air in a dental office. They've been sampling it and taking a look at it. And interestingly enough, the microbiota of the air that we breathe in the dental office every day is actually pretty similar to what you'd find in the biofilm in a dental unit waterline. That's right. So please do your 2-minute rinse at the beginning of the day. Do that 30-second purge in between your patients. Make sure if you've got a tablet system that you've got a good tablet system, that you're changing it regularly. And just recognize that that dental unit waterline, that's most of what you're inhaling all day long. It's what your patients are inhaling too. As I mentioned before, there's still a lack of evidence as to how effectively that COVID-19 is transmitted through aerosol. So it's not to say it is or it isn't, we just have a lack of evidence. Research is ongoing, and I'm optimistic that in 2021, we're gonna have a better handle on things, at least towards the end, because right now they're probably in the midst of these studies, collating the data, publishing. It's coming, it's coming. I wanted to end on a little high note with all this sort of stuff. It's a lot of concern about risk and this and that and everything. Well, in the Journal of the American Dental Association, they did publish in the fall about a study that was done in June in the United States, and they followed over 2,000 dentists for the month of June of 2020. And the positive testing rates were very low. It was about 20 dentists. And I don't even think that was from dental office exposure. It was from something else. And the authors felt that this meant that the things that we're doing are working. And it's making it that it's sufficient to prevent infection in dental offices. So I hope that gives you a little bit of peace of mind, because that was back in June, so we were just like getting started, working, getting things going, and the testing rate was actually lower than the rest of the population. So I think that's a good, strong indicator that we're doing things right. But the question is, what are we doing right? And what is it that works and doesn't work, and how did our bodies come to the conclusions of what things we should be doing? Well, it all comes from the concept of a hierarchy of controls. Let's take a look at that. You've probably seen this in literature. It could have been in the college manuals or something from the association, or in other healthcare industries, or even on a construction site. The hierarchy of controls is a universal concept that's used for worker and workplace safety. It's an inverted pyramid. The top of the pyramid is our most effective things. The bottom of the pyramid is our least effective things. So as you can see at the top, eliminating or substituting is the best you can do. After that, there's engineered controls, followed by administrative or managerial controls. And PPE is literally your last line of defense. If all else fails, at least you're wearing your PPE. So we're going to go a little bit through the rest of the hierarchy in a bit deeper review here in just a moment, and we're going to apply it to the dental setting. But first, I'd like to talk about something that we call the layering principle, and it's in regard to the hierarchy of controls. They also call it the Swiss cheese model. In essence, imagine if you had a bunch of different pieces of Swiss cheese and they got holes in all sorts of different spots on the cheese, and you start layering them. Eventually, you have enough layers. If you held up the cheese, you can't see through it anymore. That's the idea of the layering principle with the hierarchy of controls. You want to have layers of protection, and each of those layers does a different job. So you've got your patient screening form and checking their temperature and doing their PPR and doing a alcohol-based hand rub. And then you're using your HPE, and then you've got your PPE on. All of these layers protect against different things. And it's a combination of all these different layers that provides the safety. So the devil is in the details. And unfortunately, you've got to sweat the small stuff, at least for the time being, as we figure out which of our layers are the most effective and what combinations are the most effective. But for now, we know that we're using as many layers as we can, and we're doing all we can, and it is effective in dentistry. So let's keep doing that. Let's take a look at the pyramid a little bit more closely. First layer is elimination or substitution. These are sometimes looking at two different layers in it, but for dentistry, I've decided to put them together into one. Elimination would be the elimination of COVID, which would be either by vaccine or vaccine-mediated herd immunity. Or if we even had a rapid chairside test that was reliable, that could be a way to make sure that we don't get somebody with COVID in the chair. For the time being, we don't have elimination or substitution. At one point, we will, and I'm optimistic that that time is coming soon. But for now, we have to work with the rest of our levels of the hierarchy. So next up, engineering controls. So this is where we really need to focus our energy, because this is the top of the pyramid until COVID is gone and we've got things under control. Engineering controls, in essence, are anything that is a barrier or a ventilation system or something that protects the worker from whatever the threat is. So this could be like, even in industrial situations, a guard over a blade or something like that. And in dentistry, we have various engineering controls, and most of them are versions of a barrier. So we've got things like, for the dentist, they can use a rubber dam, not aerosolizing as much saliva. That's a good barrier. Plexiglass at the front desk for our receptionists, another barrier. The alcohol-based hand rinses, reducing bacteria on the patient's hands. Pre-procedural rinse, reducing microbiota in the oral cavity. Still, jury's out of how effective it is on COVID, but in general, considering that we're aerosolizing saliva, I still think it's a good idea to do a rinse to try to reduce the microbiota in general. And then there's the whole idea of ventilation, closing doors, fallow time, ventilation, air filtration. A lot of research is ongoing right now about that, and we're trying to figure out what the best bet is. And yeah, that's essentially the long and short of it, is we need to get more information on how to do things so that we can work safely and effectively. And then probably our most important engineering controls are the high volume evacuation, because as you can see in bold, the best engineering controls capture aerosols at the source. So while it's fantastic to have an amazing HVAC system, that means that the bacteria is already up in the air. The best thing we can do is contain bacteria and virus and that splatter and aerosolation so it doesn't permeate the rest of our airspace. And then if we want to actually protect ourselves from aerosolization and from splatter, I recommend doing the HVE in combination with the Stahlshield. So here's a picture of me working, doing a rinse with the triplex syringe, and that has with the Stahlshield there in place. Now, before I was using the Stahlshield as part of my daily practice, I felt pretty confident because my face shield was clean. I wasn't seeing a lot of droplets and splatter, but perhaps it was my position, perhaps it was just a little further away from the patient that I wasn't seeing a lot of spray or splatter, so I felt safe. But once I started using the Stahlshield, I realized just how much splatter we're generating on a regular basis, even in my limited application. So I'm definitely doing minimal aerosol generation, but there's a little bit here and there as I decide judiciously if it's warranted for a patient at a certain time. So in essence, I can tell you from my experience with what the Stahlshield captures, super splashy triplex syringe, even if you're trying to trickle the water. And I'm not doing air and water at all, just water. And I'm trying to just feather the button. So it's just a gentle little thing, but all it has to do is it has to just bounce the wrong way and you get a big splash on there. Obviously the ultrasonic, lots of splash on there. Rubber cup polish, I've experimented with that a couple times. Not too bad. I haven't really seen anything coming up on the shield when I'm doing my rubber cup polish. So, you know, again, as those researchers that were talking about aerosol generating exposures, there is definitely all sorts of graduations to how much aerosol is generated during different procedures and how much splatter is generated. And if there's correlations between those two, I can say that's definitely, there's a hierarchy there. So the Stahlshield, by the way, if you're wondering about it, it's actually been around for a few years. It's a medical device, as you can tell from the name Prodaptive Medical Innovations. The inventors were actually paramedics who said there's got to be a safer way that we can provide some of the services we do as paramedics or in the ER, because they were very splashy procedures, oral suctioning and some other things they'd have to do, including wound irrigation, a lot of splashback. So this was a solution to try to make those procedures safer for the operator. So you're not wearing your patient's bodily fluids. Instead, they're captured. Makes sense to me. They did a study, and this was using Staph aureus as the challenge. And basically, they were testing areas around when they would do a procedure, a simulated procedure, with the Stahlshield protecting and without it. And you can see without the Stahlshield, you have an enormous amount of those colony-forming units occurring. But with the Stahlshield, greatly diminished because it's just capturing that splatter, so you're not getting that contamination throughout. In conclusion about the Stahlshield, it's just a fantastic tool because you are taking your HVE, which is already an effective tool. You guys have probably heard the stats already that generally, if you use the HVE appropriately, it's 90% effective at reducing aerosolization. So that's only 10% is being released. But I'm telling you, it's not an effective splatter capture tool. And as I've mentioned, splatter is part of the threat, and it's part of what you wear and your patient wears. It can make your donning and doffing more hazardous. Want to be as safe as you can. And it attaches to equipment that you already have. It's going to protect you. It helps to protect the air in general, so you're going to have better air quality as well. The picture, if you're wondering, the dentist using, he said he'd like to try it. Here he is just doing a little bit of finishing of some composites that were done on the lower anteriors, and what a splashy procedure. Lots of aerosol generation, and that's what the HVE capturing it. And we, like many offices, we upgraded our HVAC system, the suction. It's really powerful and it does a great job, but it's just not, the HVE is not a great splatter control tool. That's just where it's at. Let's move on to the last couple in the pyramid. We've got administrative controls. We do these excellent in dentistry. We've got our staggered braking. We do patient screening, which Dr. Bonnie Henry said is the most important thing for us to do. Restricting visitors. While it's not mandated in BC, a lot of offices are doing a fallow time and just doing things like posting signs, providing training. These are all managerial or administrative controls, and they do make a difference. Last but not least, PPE. You guys know this as well. All the stuff that we're wearing to protect ourselves. It works, it does help. But what I want you to think is that PPE shouldn't be your barrier to stop everything. It should be the last place to catch stuff. You want to focus on things higher up the pyramid. That's what should be catching all of our risky things. And we should be just catching the last little bits with our PPE. And some people have asked the question about level 3 mask versus N95s and stuff during the course of COVID, especially now with variants coming out and things like that. And the college at this time is recommending that the level 3 is adequate, but I feel that you need to decide for yourself what is best for you. So if you're wondering, should I upgrade or not, you got to think about questions like, am I immunocompromised? Do I live with someone who's immunocompromised, or does somebody who's immunocompromised rely on me for their care or bringing them things and stuff? And also, what do you know about your patients in your chair and things like that? So you got to decide on your level of comfort. So you can upgrade to higher levels of protection if you feel you need it. But the bare minimum is that level 3 mask and eye protection, face shield preferably. And if you feel comfortable with that, stick with it. And if you feel that your situation warrants a higher level of protection, go for it. The only thing I would add as a caveat, though, is that double masking is a way that you can actually cross-contaminate. It's much more difficult to don and doff when you're double masked. So please be cautious. If you decide to do this, you need to be very cautious to make sure you're not cross-contaminating in the course of donning and doffing. So in conclusion about these layering, just make sure you're always layering. Consider layering from the top of the pyramid and rely on your PPE as the last thing to look at. Now we're going to quickly switch gears, just the last few minutes of the presentation. I'm going to show you a little bit about the other half of safety during COVID-19, which is ergonomic safety. Please don't be like this lovely lady from my very, very old textbook. We want to be safe, and looking at your basic ergonomics is a great way to kind of re-jog yourself and say, why am I hurting? Why am I so sore? This hand scaling is killing me. There's ways to make your hand scaling easier. Let's just run through a few. The first is your wrist position. Are you spending all day in a cocked position? Are things like really like not comfortable? Where's your wrist? You want it to be nice and neutral. You want your forearm and your hand to move in unison, have that nice wrist forearm action, none of this sort of waggling around. Make sure you're staying nice and strong. Consider your grip position. This one was a little surprise one for me because I thought my grip position was pretty good. It wasn't like this picture, but I found myself in this position a lot where it's sort of close to my first knuckle there. But I would find that my hands would be fatiguing quickly. Instead, you want that instrument to be supported in the V or very, very close to it. And I found that when I was using my universal scalers, that a lot of the time I would look more like this, because in order to get my correct adaptation, I had to sort of snake up my hand a little bit. And when I went back to my site-specific scalers, like my Gracie's, it would drop back into the V and adapt to the tooth as well. So if you've kind of fallen off using your site-specifics, for example, like the Gracie's, I recommend revisiting them because they really fit well in your hand, so that when you're doing a lot more hand scaling, you should fatigue a lot more slowly. I mean, there's still going to be hand fatigue with doing a lot of hand scaling, especially if it's tenacious. But if you practice these good hand ergonomics, you're going to find your hand fatigues more slowly. Sharpening, that's a biggie. If your instruments aren't sharp, you're going to be tired and you're going to burnish. It just makes your job so much harder. So many different ways to sharpen nowadays, whether you kick it old school like I do, or if you use one of the new sharpeners, whatever works for you, make sure your instruments are sharp. I'm a big fan of the saddle chair. I've been using one for many years now. I stopped using my old stool because I started getting tingling in my hamstrings. I'm like, this is not good. So I switched to a saddle chair and I've never looked back. I actually own 2 of these so I can move them from different practices and things like that. This is me just sitting straight up in it. You can see that really nice like spinal posture. And that's just what the saddle chair does for you. So you're able to sit up really straight. If it's something you've never invested in, it's worth a try. Here's an oldie but goodie you'll remember from school. Do you remember in school how we would really focus on supine for maxillary and then a little bit higher for the mandibular? Go back to that. If you're like me, you may be just sort of having your patient mostly supine but not really moving them throughout the appointment as you do different areas. It's time to go back to moving them into the optimal position for the area that you're working in. And it's not so much for your hands, it'll be for your neck, your back, your shoulders. You'll find the strain is much less. Asking your patient to tilt their chin up, asking your patient to turn their head to the side. Don't be shy. Remember to do all those things and try not to just compromise your comfort for the sake of your patient so that they can just lie in one position. A little bit about HVE ergonomics. And these also, some of these tips also count for other stuff. Make sure you're keeping your head in a nice neutral position, just tip down slightly. Drop your shoulders, bring your elbows in, no chicken wing, can't be flying around. Keep your elbows nice and close to the body. There's a bunch of different grasps you can use with your HVE. I remember this from my years as a CDA, but I recognize a lot of hygienists don't have that experience. So there's a few different ways you can hold it. One is the palm thumb grasp, which means you're holding it like a thumbs up sign. Then you've got the palm grasp where you're holding it as I am in the picture where you're just grasping it like that. And then there's the pen grasp, which you can imagine is like a pen grasp. You want to hold it firmly, but you don't want to like grip it so hard that you're, hurting yourself. And generally the literature says in order for us to do effective aerosol capture, to reach that magic 90% aerosol capture, you want to be 6 to 15 millimeters from the source of aerosols. Generally, as close as you can get is ideal. The Stahlshield, a little bit about that. Basically, you want to have it as close to the aerosols without hitting the patient's nose. Definitely from my experience, I find that the anterior debridement always has a lot more splatter. In the posterior, the cheeks are capturing it. You're not going to be splattering as much, but the front is a super splatter zone. And it's also a high aerosol capture zone. I see really, really tiny drops landing on my, my shield as well. Always consider that tissue retraction as you're moving anytime into the mouth, out of the mouth, or changing position. That's sort of like the first thing you're thinking is how can I maneuver around the cheek or any fleshy tissues so that it sits comfortably. I've used the HVE with the little flanges. I found that worked well. Right now, my favorite is using a standard HVE, and I combine it with a dry angle when I'm doing the posterior if I need to get into those areas. And the dry angle just keeps me from suctioning up the cheeks. Works really well. And the mirrored side just gives you a bit more light. Keeping it again close. And with the Stahlshield, as you're using it in the anterior, I always am using a longer HVE. I find that works for me, like the HVE tip itself. I'll bring it halfway down to pull the Stahlshield closer to the mouth if I'm working in the anterior. And then I'll push it back up if I'm working back and into the further and the posterior of the mouth. Here we've got palm grip versus pen grip, or sorry, vice versa. And as I'm holding them here, do you notice how firmly I'm having to grip to hold this? Here's where something interesting happened as we were looking at the Stahlshield and things like that. I was talking with Al, he's the guy who works for Productive Medical, the inventor of the Stahlshield. And we're like, it's so heavy. It's such a heavy tool. How can we make it lighter? And he looked at it and he goes, I don't think it's a weight issue. I think it's a torque issue. The way the hose goes, it's this big arc. And this is what you're fighting against all the time, the arc of the hose. So what we came up with is something called the elbow, because his name is Al and it's like a little elbow. And essentially what it is just a little tool that you can attach to your HVE and attach to your hose. It's like a little intermediary. And now the hose is dropping straight down. So basically, if you have like your regular HVE hanging there, it weighs about 200 grams. That's if it's hanging with the HVE tip going straight up. However, if you flip it over into the orientation that you're going to enter into the mouth, all of a sudden there's all this lateral tension force at that handle, and it changes the force there to 420 grams, from 200 to 420. It over doubles what you perceive as the weight, but is actually force. And just so you guys know, 453 grams is a pound. So you're talking close to a pound that you're fighting against as you're holding your HVE. This is why it's so hard to work. You've got to worry about suctioning up stuff, not getting the tongue, this and that, and your hand is constantly fighting a battle. When we put the elbow in, all of the tension of fighting against the hose in that arc fell away, and it went back down to 200 grams. So you're going to feel like it feels like it's 50% lighter, but it's actually decreasing the tension by almost 99%. It's very high. It's really amazing how all of a sudden everything drops away. And you can see here, I'm holding it just with one finger. It changes the whole balance of the HVE. Now with this configuration, the HVE is actually designed to go down into the mouth, which is the way it should anyways. It doesn't make sense for it to be something that goes straight up. It's not a good design. I'm going to show you a quick video here. And I think just based on how much time I have, I'm going to do a little fast forward because I want to show you guys working with the elbow. So here I'm working, you can see how I'm holding the HVE now, just with my fingertips. Really easy to hold. I'm no longer having that palm grip, that really heavy grip, trying to hold on to it. I'm moving into working in sextant 5 on those lower anteriors. I've adjusted it. It swivels, by the way, so it moves into any angulation you need wherever you are in the mouth. And look at my hand. Ta-da! Look, Ma, no hands. I can actually balance it with 2 fingers. Now, that's not that I recommend this technique, but just to demonstrate the stability of using the HVE once you have the elbow on it. So really an amazing tool. For me, having the elbow has been a total game changer. I have much less fatigue, and it's just so much, it's not as light as a saliva ejector. It's still a different tool than a saliva ejector, but boy, it's made that whole thing so much easier. Again, take a look at this picture, which looks easier. The big grip where you can actually see my forearm muscles tensing to hold it in place, or the relaxed grip on the other side. So what I'm advocating to you guys is that I broke up with my HVE. We had a bad breakup. He was a bad boyfriend. He was treating me poorly. I would have to work so hard to hold him in position. And he got all the credit for doing all that aerosol containment, yet I would be tired. With the elbow, it's like a good working relationship where we're working together and things are working in a more seamless way that I can get in there. And of course, the Stahlshield attached to that as well. So now I've changed my HVE into aerosol and splatter containment that is much more ergonomically comfortable. I think we're going to skip this just because of time. I'm just going to let you know, here's our summary. Basically, what I want you guys to think about from now on is that hierarchy of controls and layering anytime we're looking at COVID-19 and the future, because things are changing so rapidly. Maybe we're going to get through COVID and in 2021 and life is good, but what if 5 years down the road we've got COVID 25 or 26 and we're back to trying to make sure that we can protect ourselves? We need to work right now to make the office safer from the perspective of aerosol generation, and all of that information is going to be coming for us. A lot of it is going to be coming this year. And as hygienists, we need to work safely to protect ourselves from strain. Like we're doing all this hand scaling, we're holding the HVE. We've got to be working together to make solutions that are going to make us more comfortable for the long run. Don't forget to layer your protocols from that top of that pyramid. So getting excited about new PPE is going to be good, but get more excited about engineering controls and make sure they're at source engineering controls. So I'm much more excited about anything that says we are containing aerosols and splatter at the source, which is right at the patient's mouth, versus systems that are scrubbing the air and things like that, which are absolutely helpful, but it's like the horse is out of the barn. You know what I mean? How that old saying is, it's already, everything's released. We want to capture first. That's the most important thing. And I think that anything that's going to be coming out with aerosol generation control, it belongs with ergonomics. Make sure as you're looking at it that whoever is designing a tool that you're going to use, that they're thinking of your ergonomic safety as well. So with that, the Stahlshield, it actually provides that at-source engineering control. It's enhancing the tool that you're already using that is already evidence-based to help to control things. It's protecting you. It's increasing the office air quality. And then look at the elbow. Devices like this are actually helping to make you feel more comfortable because it's being engineered better. It's being made in such a way that it actually makes you more comfortable. It's a better HVE because we know the HVE works, but we need to make it much more comfortable. So yeah, in conclusion, protect yourself. Why work harder? Why work in fear? Why work in worry? We've got so much stuff coming out. And as a profession, we should be demanding better for ourselves. I think that's actually one of my other aha moments of COVID is that there's a lot of things that in dental hygiene, we were just presented with, this is the tool, just work with it and use it and make it happen. And I don't think that's fair. I think we deserve to have tools that work really well for us and with us. And I think we need to work together through things like our associations, our Facebook groups and things like that, and advocate for ourselves and make sure that we're making hygiene not just more safe, but more comfortable. We deserve it. Why should we work in a hard environment? And I think that's true actually of a lot of healthcare professionals. We should be demanding higher and better. So in conclusion, I want to end on a quote. Oh, sorry, before I do, I just wanted to mention that the Stahlshield, if you're interested in looking at more about the Stahlshield or the elbow, this is their website, productivemedical.com. Or if you have questions, you'll find that their email is right on the website. It's info@productivemedical.com. You can talk to the owners and you can find out a little bit more about the products. And if you're interested in even sampling and things like that, we can talk about that as well. But we're going to be coming out with a bit more. The Stahlshields are, of course, available now. The elbow is in beta testing right now. We're having a group of hygienists trying it out and getting a bit more information before we get into any sort of bigger production. But we're very excited to bring the idea of our concept to dental hygienists and also just to, just get it out there. So yeah, my conclusion for you guys today is just with a quote. And that quote is that progress is impossible without change. And those who cannot change their minds cannot change anything. So my hope is that you guys look at this as a tool to think about maybe changing some of your thoughts about how to work and be really open-minded and try different things and assess them and learn and share with each other so that we can make our profession safer and better. Thank you.
Well, thank you, Martha. That was absolutely a stunning presentation. I've gotten lots of comments through the chat and stuff. We want to share the poll results. So I'm just going to change screens here. And I will share the poll with everybody. So that was that first question we asked. Are you providing any aerosol generating procedures? Yes. It says 80% are saying yes, 3% are saying no, sometimes 10%, and 7% are not providing patient care services. So does that surprise you, Martha, or is that?
No, I think that's definitely reflective. I think most of us are providing aerosol generating procedures, but I'm sure that you guys are having the same sort of thing as me. You're being selective. You're not at all. I did a little 2-week study on my own of working with my patients, remembering how long I would spend doing AGPs with them, and it would maybe be like 30 to 45 minutes. And now I would be spending maybe 5, maybe 10 minutes at the beginning of the appointment. And then that's it. Things really changed up. So I think everybody's doing a little bit, but we're changing up how we're doing it. But the key is, how are we going to do it safely, right?
Great, thanks. We are slightly after 8 o'clock, but I know that there's been some very active competition between questions. They've been popping to the top and then other ones go up because as people vote for the questions. So I'm going to start with the top few, and for those that have to leave us, thanks for coming. And please complete the survey before once you leave the webinar. The survey should automatically populate. It'll only take you a couple minutes, and it's very helpful for us to have good feedback. So please let us know what you thought. For those that are going to stick around for a little bit, I'll ask you the question. So the first most popular question: would the splatter guard, so would the Stahlshield also work with the PureVac systems, and I'm assuming other systems as well?
Yes, there's a diaphragm in the center of the Stahlshield, and it's a very flexible material. So it can go around, pretty much any type of HVE system. You're just going to have to be able to flex it over. So I think it would be adaptable to the PureVac system. I actually haven't tried to pull it over. It may not go over on the mirror side, but certainly maybe pulled over from the other. I'd have to look into that, but generally it is adaptable to the diaphragm is adaptable to any HVE.
Okay. Second question: is there any information on how often transmission of COVID is occurring in the dental office from patient to hygienist and vice versa?
Correct me if I'm wrong here, Wendy, but I think that the CDHA released some information at the end of 2020 saying that they hadn't had any statistics of dental hygienist to patient or vice versa. Is that?
Yeah, I don't know if there's any, but I know that anything that I've seen coming out from the US or in Canada, it's very we're not seeing transmission in the dental office environment, essentially.
Essentially, at least in the operatory, I do know that there's been some cases of staff room transmission.
Yes, yes.
So, again, making sure you have your staggered lunch breaks is super important. That's a big thing because we've had transmissions the same way any other office does in the lunchroom, but those are limited. But it's just been a couple of times. But to my knowledge, it's not patient to hygienist or vice versa.
Okay. Next question: which pre-procedural rinses are considered to be the best for this particular virus? That was a very popular question. Are you aware of that right now?
To my understanding, we still don't have a front runner. There's a lot of research underway. I understand the initial one of hydrogen peroxide, which was very popular, is now considered not effective for COVID. And in the interim, as they're trying to decide what data is best, they're recommending kind of go back to our old standbys. In my office, I'm using Listerine as my PPR. The original formulation with the essential oils and a little bit of alcohol in it. I know that's definitely antibacterial. The jury's out still about whether it's antiviral.
Right. I think there will be some information on the BCDHA website from the Return to Work Committee. I apologize, I have not been keeping up with every piece of COVID literature, and pre-procedural rinses is not one that I'm currently very up on right now. But if you go to our website, the Return to Work Committee, which was a group of hygienists, has a section, I think towards the end, has something on PPR. So if you can't find that, please just email me, wjobes@bcdha.com, and I'll send you the link for that. Here's a question: is it difficult to see through the Stahlshield, or is it awkward to use with ultrasonics?
I found that in general, no, it's not. I'm using loupes, face shield, and the Stahlshield, and I'm still able to look through it. I also have a light that is attached to my loupes. The light is going through my my shield and through the Stahlshield. On occasion, if I tilt my head at just the wrong angle, I get a reflection, and I don't know what that reflection is, a culmination of all of the plastics that I'm looking through or not. But all I have to do is just tilt my head a micro bit one way or the other, and then that reflection is lost, and then it's good. If I'm doing a procedure that, especially like say anterior ultrasonic, and it gets pretty splashy, I do a technique of rotating the Stahlshield so I can have a less splashy area if I need to work on another area. The splatter dries really rapidly in the presence of the high volume suction. So splatter does dry very rapidly that way. I found it hasn't been hard to look through.
Great. Several questions about, you mentioned where to get the Stahlshield, so the website, and what about cost, and is it all collapse these two questions. Is it autoclavable or disposable?
Okay, so because it was designed for use in ERs and things like that, right now it is the medical version of it. It is packaged in a sterile package. They cost $3.50 each. They are manufactured in British Columbia. They're 100% Canadian product, and they're in their sterilized bag. They come in boxes of 25. Depending on how your comfort level is, this is a device that is never going intraoral. It's always extraoral. You can consider doing a cold soak for it because the current incarnation is not autoclavable. I gave it a shot, and while it didn't distort, it made the plastic cloudy, so it's not autoclavable. But I've been in talking with Productive Medical. I've said having an autoclavable Stahlshield would be very important for the dental profession. We would prefer that. And so we're actually in the works of looking at a Stahlshield that's going to be thinner, slightly changing the shape so it's better for hygiene, a little bit lighter, maybe by 20 grams or something, but every gram counts with that HPE, and making it autoclavable. So that's coming in the future.
Okay, we're going to do one more. How does the elbow unit holster on the delivery unit, and does it use the same receiver?
Yes, I had to just because of time, I fast forwarded through a video, guys, that actually shows how it goes onto your HVE. But we're going to put that on the Productive Medical website. And you can watch like a 2-minute video of me taking apart your regular HVE, and you just pull it apart, you stick the elbow on it, and it all sticks in together. And the swivel point that you usually have on your HVE becomes a swivel point on the elbow. So I apologize that I didn't have time to share that with you guys today, but we'll have a video on Productive Medical that you can watch. Maybe we'll throw it on YouTube as well, so you can see it that way. Very easy to put together on your HVE, and very easy to reverse back to conventional HVE if necessary.
Great. Thanks, Martha. I have to thank you again and again and again. That was a fabulous presentation. We're very lucky to have you provide this information. It's well after 8, so we're going to close off tonight. Please complete our survey. Once you leave the Zoom room, you will be directed to a survey. Please take a few minutes to fill that out. We really appreciate your time to give us your feedback. And I will give you, there's my email address and my telephone number. That's my cell. So please call if you have any questions, or send me an email. If I think we got to most of the questions. There was a couple that we didn't get to, but if you're a real keener, send me an email. I'll beg Martha's to give us an answer to that question.
Yeah, I'm just forward them to me, Wendy. I'm happy to answer more questions. If you guys haven't figured it out yet, I am a total dental nerd, and I spent a lot of time during closure reading articles and collating all sorts of information. And I'm so glad I had the opportunity that BCDA DHA offered me to share it with you guys, so that you guys don't have to do. Might be boring for you, but for me is a lot of fun, and I want to share more, and I want to learn what hygienists think about what they really want. Like, I know what I wanted, but what I want may not be representative of everybody. We want to make the best tools for dental hygiene.
Absolutely. Well, thanks, Martha, and thanks to everybody that joined us this evening. We look forward to seeing you at our next events, and take care and be well.
Yeah.
Good night, everybody.
Take care. Thank you. Bye-bye.
And and one thing before you go, Martha, thanks to Al and the Productive team for supporting you to be here tonight.
Yes, I'll pass that along.
Okay. Good night.
Good night.